Okay, we're back, and thank you for those calls, Chuck and Ray. Um, but to basically say that the kind of the fix is in on all those things, I think it's important that what you can do out there is to try and screen for those cancers that can be screened for, so as to not let yourself be, sucked down into that cesspool of hope and then gloom and doom from getting treatments that basically don't really work. And to say that miracles don't happen with cancer, that's not true. Sometimes it does, but really the key, until we can get some of these newer technologies out there for everybody, is early detection. So, I encourage people, to get those colonoscopies. They're not really easy to get up here. The hospital does do them with Dr. Sorensen, but, all cancer, all polyps, if allowed to exist long enough, will turn into cancer. And they can be detected and removed with a colonoscopy. So that's one form of death prevention that is easy enough to do. Mammograms really they're very uncomfortable for females, and they have not come to the point where you can get an MRI or some other way, but the reason they're so painful is because they squeeze the breast to use less radiation. And what they're looking for is, specific changes in the breast tissue, what they call microcalcifications, clusters of different calcifications. The theory behind that is that, again, breast cancer or any type of cancer, as it starts to grow and divide, outgrows it. I mean, it's a fast-paced life. And those cells, they live and then they die. And when something dies, calcium sets in. So a microcalcification or a cluster of calcifications, a spiculated looking area on a mammogram, can be suspicious for breast cancer. And it's usually being able to be detected years before you can palpate it. Once you feel a breast cancer, pretty much over. If you can see a cancer on a chest x-ray, pretty much over. Because it's been there a long time. I mean, it could be as many as 5 to 10 years before it gets big enough to double. And you talk about cancer doubling rates, one cell goes to 2, 2 goes to 4, 4 goes to 8. It doesn't really happen along that linear progression because some of the cells die before they can actually reproduce. But it is depending on the aggressiveness of the tumor, can be quite rapid or quite slow. Some cancers, like prostate cancer, in males are very slow-growing tumors, and usually the male might die from some other reason other than prostate cancer. Not necessarily true if you get it at an earlier age, and just like breast cancer, where it tends to be more aggressive when you're premenopausal, because, like I said before, estrogen and that particular drug promotes estrogen and progesterone may promote breast cancer development and growth. So those young premenopausal women who develop breast cancer usually have a more aggressive tumor, and it's much harder to treat because of the numerous estrogens that are available. As you're an older female, estrogen does raise the risk of breast cancer 8 per thousand. It doesn't seem like a lot, and we don't prescribe estrogens anymore for osteoporosis prevention or things of heart prevention. They found it works the opposite in all of those categories. And it's almost a drug you really don't want to prescribe. But if you're a female and you have hot flashes and your life is unmanageable, this is what I tell some people: it doesn't really matter. I mean, it does matter if you were to develop cancer, but if your life is miserable just to avoid cancer, and your life is just, it's not, what fun is that? I mean, you just have to take some chances in order to have a better life. I don't see that often, but that's the thing about estrogen is I don't know that, I don't really prescribe it that much anymore, except as a female's been on it. I came from this time when it was widely prescribed to now to a time where it's very hardly prescribed, and there are some medications that have the good parts of estrogens without the bad parts, and those drugs can sometimes promote bone mineral density and a few other things. So at any rate, getting a colon cancer screen is very important. The prep is really not as bad as people think it is. The problem with it is you have to drink a lot of fluid to wash out your intestinal tract, and you have to be on a clear liquid diet so they can actually visualize your colon. It's not a diarrhea that you get from the colon prep. It's just a lot of fluid, and diarrhea normally when you get it has a lot of bile and a lot of acid, so it tends to be very irritating to the lower intestinal tract, and it's a lot of cramping. But you don't get that with the prep. You expel a lot of water and a lot of fluid, and that's what you're supposed to do. And sometimes that's a different sensation than some people are used to. So, but other than that, you have to be driven down or do it up here. I think Dr. Sorensen at the hospital does a few of those, even though I think he would probably rather be doing surgery, but he does do them. And I think he does a very fine job. So, but not all insurances are going to cover Desert View Hospital, so that could be a problem in that respect. But I did do on the show earlier in the year a fecal globin test where it showed you how to use a card to sample your stool, which some people don't really particularly like, but I mean, that's something that sometimes you have to do if you want to check for colon cancer. So that aside, mammography, we did talk a little bit about that. Females should get the mammograms done every 2 years is the number to treat. If you go to the hospital, they may send you a thing every year, but that's not necessarily you have to do that unless there's some abnormality found on your previous mammogram. You have a high history in your family of breast cancer, then you might want to consider doing that, and then they get it biopsied, and usually if you can catch it early enough, you can actually be cured on that particular area. Skin cancers are one of those things that we're prone to here in Nevada because there's a lot of sunshine. It's a good idea to get into your doctor to look at your skin. Not all dark spots are going to turn into melanoma, and there is a rare condition called amelanotic melanoma, which means it has no melanin. So you usually get that and you're dead. I mean, they won't see it until it's just all over your body because there's no lesion for them to pick up. Very, very rare, but it does indeed happening. Basal cell cancers, saw one right before I came on the TV show. My last patient thought he had ringworm on his forehead, but it was a slowly eroding basal cell cancer. Those are very treatable. If it gets big enough and it's a bad place, you have to treat it with a little radiation, maybe a little chemo, but it's not going to be a tumor that's going to metastasize deep into your body, but it is going to erode and remove and denude your skin and turns quite ugly and can be quite a problem. Squamous cell cancer of the skin can look like basal cell, but it tends to be much more aggressive, and that's the kind of cancer that does metastasize. So certain tumors, like, Chuck talked about melanoma, very rapidly metastatic tumor. It has a lot of embryologic stuff and early development, and it can spread very rapidly through your body. And people don't realize it, but there's a lot of melanin in your eyes, so getting your eyes examined regularly is a good way. I've seen, and rarely, seen 2 cases of melanoma of the eye. It does happen, and that can sometimes be another fatal problem because of where it is. So if you get your eyes checked regularly, you hope to avoid that. And look in the back of your retina, determine whether or not high blood pressure problem, diabetes, any other particular problems do manifest themselves in those particular lines. Now, I don't suggest that you get tumor markers. I know some women like to come in and get a CA-125, which checks for pelvic and omental tumors. They like to get the CA-27-9 for breast cancer, CA-19-19 for pancreatic cancer. So what this is basically some tumors produce a protein in your body that you can actually run a test for, and you can actually pick it up. But it is a backward way of screening for cancer, because not all proteins that resemble cancers are actually true tumors, meaning your body can make what we call false positive tumor markers. And so if you come in and want a CEA, which is a carcinoembryonic antigen, which is very useful in people who have colon cancer, and I do that on you and it is elevated, then we're chasing a ghost. You may or may not have an adenocarcinoma or a glandular type of tumor. And if I can't find anything or you don't find anything and this level is high, you live with a cancer ghost for years trying to look for something, and it's a very miserable existence thinking you might have cancer, but only to find out that you don't or something else is going on. Anyway, we're going to take the break before we get in the last segment. And Ray, if you have another call, now's the time after the break. Thanks.